This is a video of laparoscopic cholecystectomy in previously attempted acute chole. The surgeon referred me, he attempted acute cholecystitis and he couldn't do, and he keep a drain and then he referred to me. So that is the drain. So I went into laparoscopy. I'm just checking that all the area, doing a diagnostic laparoscopy. That is the left lobe. A lot of adhesions. So what I did, I put a left lumbar 5 millimeter trocar and then I started separating the adhesions. It was a very dense adhesions, treated with antibiotic for some days, and then it's not settled. Then he referred to me. So that may be the gallbladder region. It was very densely adherent. You can appreciate when I that is a gallbladder. When I try to remove from the using the suction nozzle, you can able to feel the hardness. By seeing the video, you can able to feel the hardness. So it is a treated case. That's why our preference in gym hospital preference is whenever the patient comes, we operate. We don't treat conservatively and then we'll take the patient. If you treat conservatively, it becomes very much hard, and most of the time it will not settle even with the higher antibiotic. So this case, it is a treated case. You can see it is well organized. Omental adhesions I am trying to separate from the gallbladder. So that is the drain, a previously kept drain. You can see there is a tissue within the drain. So now I'm placing the epigastric trocar. Nowadays I'm placing only 5 millimeter trocar first, then I convert it to 10. This is the old video. See, I'm trying to separate. Usually it will separate very easily, but this is very much hard. Close to the gallbladder wall and the liver surface, we are separating the omentum. Now I could able to see the lateral wall, and I am placing the right lateral port for retraction of gallbladder. I am using the grasper to hold the gallbladder. Gallbladder wall is thickened and I am not able to retract because momentum is holding very tightly. So I'm started pushing the momentum down. Suction nozzle is it's like a finger dissection in open surgery. We can use the suction nozzle. These are all the developmental adhesions or the very dense adhesions. I'm dividing with the harmonic scalpel. Very much hard. You can see, it is like a stony hard. So not able to dissect further. In acute coli, I was told in the previous videos, my aim is to identify the infundibulum, and then I take the infundibulum down from the post attachment so that I can able to. So this is the extra port I made it left lumbar region for a retraction of the duodenum and the omentum. So this will give a good exposure. Now you can see the exposure is good. I started doing this, dissecting the thickened peritoneal covering of the infundibulum. My idea is if you open the peritoneum, then infundibulum is coming out, so that I can able to identify the calyx. So I'm trying to separate. Now you can see how much thick the peritoneum is because of the repeated infection, and they treated with the antibiotic, so it became a thick. So I could see the infundibular wall, but I'm not able to separate it. It is not coming out. Can you see how much pressure I'm giving? And then duodenum and the omentum also is pushed down. So even though I'm not able to, it is not even a 5 mm or 5 mm is coming out, from this. I'm not able to mobilize. So I started doing anterior dissection now. If I able to dissect anteriorly, then infundibulum, no, that is the infundibulum of the gallbladder. I want to take it posterior, but I couldn't do posteriorly. So slowly I'm trying on posterior side and anterior side alternatively. It was like a, no concrete. It was like a very stony hard. So when I pull, not even a is coming out. See, when I pull, no, it's like a same. It is not. It's coming. Usually in acute situation, it will come out easily, so that we can able to identify the anterior structures like a cystic artery and duct. So slowly, I'm proceeding now. Can you see when I push down, the tissue is not going down. So I'm giving my extreme force, but even though it is not coming. So that's why the acute cholecystitis to be operated at the early stage, not by after treatment. So that looks like a artery there. I'm just taking. Now you can see the gallbladder wall. I'm able to dissect. I'm doing all the maneuver with the suction, with the Maryland dissector. I don't want to do subtotal cholecystectomy, so I'm trying to dissect the. So now you can see the lateral wall of the gallbladder is being able to dissect now. See, I'm holding it. So that is the lateral wall of the gallbladder. So that looks like a cystic artery. So that is looks like a cystic artery, but it was densely adherent to the gallbladder wall. I'm using a suction, this one gauze piece to clear that area. So that can be clipped and so that is the one. No, it's that can be clipped and divided. But I'm trying to skeletonize the cystic artery, but it is not possible. So I'm just dividing it. Even better to apply clip and then divide it. I try to divide with the harmonic scalpel. So there is a bleeding. No, that is the cystic artery. You can see the bleeding there. So I am applying clip now. So the clip is applied to the cystic artery. Cystic artery is clipped, and then I could able to see the anterior wall, no, lateral wall of the gallbladder or medial wall of the gallbladder. So I'm just I'm trying to go behind that, encircling the gallbladder at the level of infundibulum. So here it is like a stony hard. I'm not able to move down. That looks like a small artery. Very much hard tissue because of the fibrosis, repeated infection, and they treated with antibiotic. Repeated it became a fibrosis. So you can appreciate here the gallbladder become narrowed. It was open now. So I'm separating the posterior wall of the gallbladder. So once I dissected or encircling the gall, now you can see it is going a little bit narrowing. It is not a distended one. I could see the narrowing of the gallbladder there. So that is the infundibulocystic junction. So what I feel is that will be the infundibulocystic junction, and imaging wise there is a stone in that junction is there. So that may also produce much fibrosis, infected stone. So I could able to encircling the cystic duct. You can see one 5 mm instrument from left lumbar how much exposure. No, it is entirely retracting the duodenum and the omentum. Sometimes colon will be there. You can retract the colon with that instrument. So that lumen was open. So it is a narrowing. It is not like a big cavity. So that will be within a 5 mm or within a centimeter. The CVD will be there, and then I am expecting stone from that place. Imaging wise, there is a infundibular neck stone. So I'm divided it. Now you can see it is very small diameter compared with the gallbladder. So it might be the very lower part of the infundibulum or infundibulocystic junction. I'm not able to see the stone. I could see the lumen. See, the stone is here. Can you see that is the stone? Exactly at the infundibulocystic duct, it is stone is there. Sometimes it may be the type 1 Mirici syndrome. Type 1 Mirici is the cystic duct and CBD junction. There will be a stone. By taking out the stone, the lateral wall of the CBD will be open. We have to suture that. But here it might be the Mirici type 1, or it will be the lower part of the infundibulum. Cystic duct will be very much obliterated because of this press of this long time pressing of the stone, and it is a quite big stone. Usually I take it with the milking out, but here milk out is not possible because of the surrounding very much hot. So now you can see that there's such a big stone. And if bile flow is coming, bile is coming very golden yellow bile is coming freely, that means that is a type 1 Mirici, that is the lateral wall of CBD, common bile duct. But here it doesn't, bile is not coming. Bile is not coming means two things. That my one thing is might be the another stone. Second thing might be the obstruction of the cystic duct CBD junction. So how to confirm whether a stone is there inside or not? Uh, so I'm trying to dissect further, and for a better exposure retraction of the liver, I'm releasing the inferior surface adhesions, inferior surface of the liver adhesions. Everything I'm releasing now. So everything is like a stony hard here. Very narrow space without the retraction of the duodenum and momentum. I couldn't have any space. So I'm trying to dissect. It's again it's hard. I'm not able to proceed, and I'm not able to feel any stone. Any hardness is not there. Previously that hardness is there. Now there is no hardness. So that is the wall of the gallbladder, serosal wall of the gallbladder left behind. So it is a subtotal type 1 and 2 you can take. It says type 3. There is a difficult hilum and difficult liver bed both. So it is called type 3 subtotal cholecystectomy. There is no bile. So I am suspecting another stone or uh, obstruction of the cystic duct CBD junction. I am trying to go a little bit medially, but everything is too much hard. I am not able to separate. So I have to confirm whether stone is left behind or not. So what I did, we have a facilities in GEM hospital, laparoscopic ultrasound. So like ultrasound, we used to keep outside, but this is the laparoscopic ultrasound. We used to keep it on the CBD or on the liver or on the pancreas. We can able to keep. So I'm planning for. I asked for a laparoscopic ultrasound, and ultrasound probe will be there in the OT. So the CT ultrasound radiologist is. I call the radiologist. So I'm taking this ultrasound laparoscopic ultrasound probe. Now you can see in the picture-in-picture image. When I keep this ultrasound, I can able to see the common bile duct, and with the Doppler, I could able to see the hepatic artery. You can see this color, red color, and then down will be the portal vein. So this is the full screen. My radiologist is explaining, and you can see I'm operating with the 4K system with the 55-inch monitor. You can see my laparoscopic monitor, and I'm using a PAPR. This was done during COVID time, so I'm using this with all the protection. I'm doing it. So so this is the full image. You can see the hepatic artery, portal vein, and the common bile duct. There is no stone. There is no stone. It was entirely ruled out. So this is one of the very good diagnostic tool. Since we are keeping the ultrasound probe on on the CBD, we don't miss any stone. So finally, I'm started suturing the infundibulocystic junction. I'm using a 20 PDS here. So the stone is extracted, and I confirm with CBC, no other stone there, and then CBD also normal, little bit dilated CBD, but there is no stone. The surgeon referred this patient. He is a senior surgeon, and he tried because of this very much stony hard of the tissue. He couldn't proceed. So he keep a drain, and then he called me, and then he send the patient next day. I've done a few cases like this. One case is the surgeon attempted laparoscopy, and then he opened, and then even with the he couldn't able to proceed because of the same, like, like a concrete. All the structures has become very much hard. He couldn't proceed, and then he called me. I'm putting only the skin suture, and I'm sending it to you anyway. You are going to do open gallbladder removal. I said, no, 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 I don't do open. Close all the layers of the subcostal incision, and then send the patient to me. I'll do laparoscopy. That patient also I did laparoscopy, and then with ultrasound guidance I removed all the stone. There is a two or three stones was there, like this much big stone, and then the patient went home normally. So this laparoscopic ultrasound is the one. It's helping us in a difficult situation. Uh, so we could able to do the complete surgery with the help of laparoscopic ultrasound. So now I have to remove this gallbladder. Again, it was very densely adherent. I am trying to take it out all the layer. Otherwise, I leave the serosal layer of the gallbladder, and the entire mucosa of the gallbladder will be removed. So anterior full of gallbladder, posteriorly serosa will be left behind, and mucosa will be taken out. So basically, it is called type 1 modification. That is a difficult liver bed. Type 2 modification is the difficult hilum. Here, I cannot call it a type 2, but anyway, it is a cystic duct, CBD, cystic duct and infundibulous junction suture. So it can be called type 1 also. So that is a mucosa. What I'm holding is the mucosa of the post wall. We cannot take the anterior serosal wall, posterior wall. So the seros of the post wall I left behind with the liver. And some of the contracted gallbladder, again, we use the laparoscopic ultrasound. In empyema and gangrene gallbladder, I put the video previously. It is not required because we could able to identify all the structure. In a treated case or long time pending cases, so some cases they went to acute chole, then they treated, and then again the patient symptomatically better, and then again after some time again acute infection will be there again. So like this multiple time treated case, the tissue will be become this like an organized tissue, then we're not able to separate. So in those cases, laparoscopic ultrasound is very much useful. This was done almost 5 years back in COVID time, and you can see we can able to complete the procedure laparoscopically. It was attempted by one of the experienced surgeon nearby city, but even though he is not able to proceed, but we have a facilities, infrastructure, experience, and 4K vision. So all those things you must have seen that big monitor, 55-inch monitor, and the 4K camera. So all those things is very much important, and in this type of acute cholecystitis, and along with the surgeon experiences plays the major role into by operating this case. These are all the very much challenging case. Even in open, no, this much difficulties will be there. So there is no space there on the liver surface. I'm just keeping the endo bag. I'm placing the excised gallbladder and the stone into the endo bag, and then I'll divide into piecemeal I cut the gallbladder because it's thick walled. I cannot take it through the 10 millimeter. I cut and then I am taking it through the 10 millimeter toker. I don't extend the incision. So that is another stone there. So one stone on the infundibulum, one stone on the infundibulocystic junction. The infundibulocystic junction is stone is a packed. So stuck stone, it's not able to. This stone is stuck to the junction, and by opening the infundibulum, I could able to take out the stone. So this completes the procedure. So with this experience over 25 years, and any gallbladder, any difficult gallbladder, we can able to manage laparoscopically, and then we never open for almost all 25 years. We could have all type of difficult gallbladder in our hospital, and since we have all these infrastructures and the surgeon's expertise, and we could able to finish this type of complicated difficult surgery laparoscopically. Thank you so much.